Dear students, today we are going to discuss about the anti-GBM disease. What is anti-GBM disease? When we talk about the definition of the anti-GBM disease is the antibody against the glomerular basement membrane, and this is cross-reactive to alveolar basement membrane and produces rapidly progressive glomerulonephritis plus minus alveolar hemorrhage may be there. So this is the antibody against the glomerular basement membrane, and often this is cross-reactive to the alveolar basement membrane, means there may be the antibody formation against the alveolar basement membrane, and there may be the rapidly progressive glomerulonephritis plus minus alveolar hemorrhage. So this is the definition of the anti-GBM disease. So some terms are used when we talk about this disease. One is the anti-GBM disease. What is anti-GBM disease? Anti-GBM disease when there is only kidney involvement. When there is only kidney involvement, this is called the anti-GBM disease. What is Gush-Pasteur syndrome? Gush-Pasteur syndrome when kidney and lung both are involved, which is also called the pulmonary renal syndrome. So Gush-Pasteur syndrome is the when kidney and lung both are involved. This is called the Gush-Pasteur syndrome. One terminology is the Gush-Pasteur disease when the kidney and the lungs are involved and there is serology positive, anti-GBM serology is positive. So this we call it Gush-Pasteur disease. So three terminology: number one, anti-GBM disease; number two, Gush-Pasteur syndrome or pulmonary renal syndrome; number three, Gush-Pasteur disease. These three terminology are basically used. Now we talk about the antigen. What is the primary or principal antigen which is responsible for the production of these antibodies? So this is the alpha-3 non-collagenous region of type 4 collagen. Alpha-3 non-collagenous region of the type 4 collagen, which represent as an antigen, and antibodies are formed against this antigen. So this is the principal antigen which is responsible for the disease. Now what is the trigger? For auto-antibody production is unclear, but sometimes cigarette smoking or some other irritants may involve in this conformational changes, and that unmarks the EA and EB epitopes. So there may be the conformational changes and they unmask the EA and EB epitopes. And what are the responsible? Maybe the cigarette smoke, maybe some other irritants are responsible for this kind of conformational changes. Now, basically what happens? These antibodies against this collagen, alpha-3 non-collagenous region, these antibodies are basically linearly binded. The binding of the antibodies is linearly and to the glomerular basement membrane and induces the crescentic glomerulonephritis. Now what is the epidemiology? When we talk about the epidemiology, 0.5 to 2 cases per million per year usually are found of the anti-GBM disease. So in this respect, this is the rare disease, but 0.5 to 2 cases per million per year usually found of this disease. And there may be two peaks of incidences. The disease may present in the early young age, adult male, or the disease may present in the old age, and sometimes it is associated with cigarette smoking and hydrocarbons and some infections like virus and some drugs also like alemtuzumab may be responsible for this disease. So this is the epidemiology. So we have discussed the definition of the anti-GBM disease, we have discussed the terminology, and we have discussed the epidemiology. Now we come to the clinical feature. When we talk about the kidney, there is presentation that this disease presents with the hematuria plus minus proteinuria, and usually the disease progression is the very rapid, and which we called it the rapidly progressive glomerulonephritis. So in the respect of the kidney, the disease presents with the hematuria plus minus proteinuria, and there may be the RPGN, rapidly progressive glomerulonephritis. And when we talk about the lungs, the symptoms related to the lungs may be the hemoptysis, maybe because of the lung hemorrhage, there may be the hemoptysis, there may be the cough, there may be the short of breath, there may be the tachypnea. So these are the symptoms related to the lungs. Symptoms related to the kidney, symptoms related to the lungs. Usually the constitutional symptoms are usually absent, and the young patients are usually more fulminant than the older patients. Means this is the disease is more fulminant in young people. So constitutional symptoms may be absent, but young patients may present with the fulminant disease like kidney involvement and lung involvement, as we discussed, in the form of RPGM or maybe in the form of hemoptysis due to the alveolar hemorrhage. Now, pulmonary involvement usually is associated with some kind of irritants like smoking. So this may present, the pulmonary involvement may be associated with some irritants like smoke of the cigarette. Now, what is the diagnosis? Basically, we diagnose the disease with the kidney biopsy. When we do the kidney biopsy, this is the crescentic glomerulonephritis with linear IgG. Usually IgG1 and 3 are found in the disease when we see the biopsy, and usually there is the linear deposition of the IgG1 and IgG3. IgG4 and IgG4 and IgM are usually rarely not found. Now, what about in the bronchoscopy? When we do the bronchoscopy, this is the gold standard for the diffuse alveolar hemorrhage. When we want to see the diffuse alveolar hemorrhage, the bronchoscopy is the gold standard investigation, and we can also do the chest CT. Anti-GBM antibodies is for the diagnosis and for the tracking of the disease. If we want to track the disease, we want to see the relapse, we want to see the improvement, then we are supposed to see the anti-GBM disease, and this is sensitive. In this anti-GBM antibodies are sensitive 60 to 93% and specific 90 to 97%. So anti-GBM disease is sensitive 63 to 93%, and this is specific 92 to 97%, and anti-GBM antibodies is for the diagnosis and tracking the disease. If the patient is severely ill, the clinical manifestations plus anti-GBM antibody may enough to make the diagnosis. So no need of the biopsy. If the patient is very much ill, very much sick, then clinical manifestation plus anti-GBM antibodies, if this is the positive, this is very much enough to make the diagnosis. Maybe there may be the ANCA antibodies positive 10 to 15% of the cases. Usually MPO are positive with this disease, so which we call the dual disease or dual positivity disease. So this is the diagnosis. When we talk about the diagnosis, number one, kidney biopsy. There is the linear deposition of the IgG, and the most common is the IgG1 and IgG3. And the second one is the bronchoscopy to see the alveolar hemorrhage, and the third one is the anti-GBM antibodies, and the fourth one, in severely ill patients, usually the diagnosis is confirmed by the anti-GBM disease and with constitutional symptoms. So this is about the diagnosis. What are the disease variants? There may be the disease variants. What may be the disease variants? Disease variants may be the anti-GBM antibodies may present with the ANCA disease, and usually prognosis and clinical features of anti-GBM disease may be associated with features of the vasculitis. So dual positivity, which we call, so this is the disease variant. Number one may present with the ANCA disease, and the clinical symptoms or the clinical features may be as a feature of the vasculitis. Number two, atypical anti-GBM disease. We call it atypical anti-GBM disease because this is the rare, but there is negative anti-GBM antibodies. They are not found usually anti-GBM antibodies, but when we do the biopsy, there are found the crescents. There is found the linear anti-GBM staining. So this we call the atypical anti-GBM disease. This we call the atypical anti-GBM disease. Now, what is the treatment? The treatment, if we talk about the treatment, if the disease is limited to the kidney, and the dialysis dependent recovery is low. If the treatment, if the disease is related to the kidney, then usually it is the dialysis dependent. If the patient is dialysis dependent, then recovery is low, and there is no need of immunosuppression. And if the patient is not dialysis dependent, then the treatment of choice may be the cyclophosphamide. We can give the oral cyclophosphamide 2 to 3 milligram per kilogram per day for 3 months. Then we can give the corticosteroids like prednisolone 0.5 to 1 gram for 3 days, followed by the prednisolone 1 milligram per kilogram per day, tapered to 20 milligram by 11 to 12 weeks. Usually this regimen we follow in the rest part of the corticosteroids. and other is the plasma exchange. We can do the daily plasma exchange for the 14 days until the anti-GBM antibodies are not negative. So this is the brief about the treatment. And so what is about the treatment? Number one, if the kidney limited, no immunosuppression, and if we are supposed to give the immunosuppression, so the drug which are the cyclophosphamide, corticosteroids, and the next is the plasma exchange. Now, what is the prognosis? So 5-year kidney survival is 94%. And if creatinine is less than 5.7, if the creatinine is less than 5.7, then 5-year kidney survival is predicted. Who receive appropriate therapy, who receive appropriate immunosuppression, the 5-year kidney survival is predicted. Now, last, what about the transplantation? When we do the transplantation, there is need of the negative anti-GBM antibodies for 6 months. For at least 6 months, we are supposed to do the negative anti-GBM antibodies. So this is brief about the anti-GBM disease.